Welcome, and thank you for the invitation to speak about our rapid tissue-based molecular testing and oncology program. I'm Lauren Ritterhouse. I'm the Associate Director for the Center for Integrated Diagnostics at Massachusetts General Hospital and Harvard Medical School. So today I'm going to be talking about our rapid NGS program and how that fits in with our overall rapid testing multidisciplinary practice here at Mass General. And so the test that I'm going to be focusing on for the first part of today is a test that we call our rapid NGS test. And it's a really automated end-to-end solution that we've recently incorporated into our rapid testing protocols. And it starts off with nucleic acid purification. So it goes all the way from extracting nucleic acids through quantitation, library prep, sequencing, and data analysis. And this is a really focused, targeted assay that covers 50 genes, and it looks for a variety of alterations. So it looks for hotspots, so the DNA, it includes both DNA and RNA-based tests, which I'll talk a little bit about subsequently. So it looks for known hotspots of actionable genes, so actual targets in cancer. We're looking at copy number alterations in a subset of genes as well. And then there's an RNA-based component to the assay that looks for fusions, so both intergenic rearrangements, things like ALK, RET, and ROS, as well as intragenic fusions and rearrangements, so things like ARV7 in prostate cancer, MET exon 14 skipping in lung cancer. Those things are detected on an RNA-based level. And the variants that are covered are over 2,000 unique single nucleotide variants in indels. And I'll talk a little bit more about variant calling in subsequent slides. And then it also has coverage for over 500 fusion-specific isoforms. So it's really quite an impressive fusion isoform coverage of such a rapid, quick turnaround assay. And then there's 14 genes where we can look at copy number alteration. Just going into a little bit more detail about the workflow and the steps of our rapid NGS assay. So it starts off with the purification step, the separate instrumentation, and then the automated workflow described previously. And there are separate DNA and RNA extraction steps. We like to think about our rapid NGS test as a single assay, and we present it as such in our reports, but it's really two separate assays and two separate extractions to get all the coverage that it was shown on the previous slide. So it's an amplicon-based NGS assay, like I mentioned, one for DNA and one that's RNA-based. And just a few brief highlights from the informatics side is that it utilizes molecular barcoding, and it performs targeted variant calling for the assay that we run. So de novo variant calling is not supported. So for SMV and indels, for example, there's over 2,000 targeted variants that it calls for. So this is a very focused hotspot panel, again, looking for known actionable alterations. And it has tumor purity adjusted copy number calling. And for looking for gene rearrangements or fusions, there's two mechanisms by which that's done. One is looking at targeted isoform-specific fusions. So this is known fusion breakpoints, known partners. And again, there's over 500 isoforms that are covered. And there's also a mechanism for looking at non-targeted fusions. So these are novel fusions, novel partners, novel breakpoints. And that can be done by looking at expression imbalance. So this is 5', 3' expression imbalance by a subset of genes. And so the runtime for this assay is approximately 16 to 18 hours, depending on how many samples that you're running. So again, this is extremely fast, maybe not in the land of stat time for chemistry labs, but for NGS assay and oncology, this is very fast, where many, especially the larger comprehensive panels can take weeks to get results back. So very, very fast turnaround time. And the other thing that's really great is the hands-on tech time is very low. And that's about an hour and a half to 2 hours. And that includes all the upfront sample preparation that's needed, sample accessioning and everything. And so in our laboratory, we have this platform validated for both FFPE as well as frozen tissue sections. And I'm going to mention our use cases for utilizing frozen tissue on this assay in subsequent slides. It's very important for our ultra-rapid lung cancer testing pathway. And on average, we use about 5 sections, whether FFPE or frozen section, although in our validation studies, we were able to get away with even under a millimeter squared of tissue, and had good technical success and performance with this assay. So it can work on a pretty small amount of input tissue, which is very, very useful in a variety of specimen types, particularly in lung cancer when we're working with very scant input, and the biomarker testing demands when you combine both genomic profiling and immunohistochemistry-based needs for tissue is quite high. So it's very, very useful to have assays that work off of limited amounts of tissue. So just digging in a little bit more, just to get a sense of what the workflow is, how rapid is this? How does this work out in our laboratory? And so on day one of this, in the morning, whatever technician in the laboratory is running this platform for the day, they would do our laboratory information management system work, accession the cases, print labels, and then time is to do that sample preparation work that I mentioned on the previous slide that contributes to the hands-on tech time. They'd have to deparaffinize the FFPE sections, prepare lysis PK tubes, and actually do the tissue scraping of our slides. We're often doing macro dissection to enrich for tumor purity. And then there's a handful of incubations, setting up the purification instrument. And then while the purification instrument's running, you can simultaneously do the sequencer prep and setup. And then our workflow, library prep, sequencing, analysis, kind of done in the evening and overnight. And then we've built a post-analytical workflow and automated report generation that does variant tiering and creates nice reports. All that happens as well. So that way, by the morning of the next day, the data was available for review, and our reports are available for review by the molecular pathologist on service. So this is just a few examples of some of the interfaces that we've built to help visualize the data and fit into our workflow and our reporting schematics that we use in our laboratory. On the right here, this is a nice visualization that we've built to look at our copy number data. We can look at all the variants and the copy number alterations that were called, quickly visualize everything in IGV. And then on the right, this is just an example of an automated report that we're able to build that includes canned interpretations from an FDA-cleared database. So it's very fast for molecular pathologists such as myself who's on clinical service to review all this and then rapidly find out the case. So now I want to switch gears and talking about our ultra-rapid protocol that's been developed at our institution for quite a few years now. And I'd like to take credit for it, but I can't. It was in implementation before I even rejoined MGH. Joe Linners, who's the medical director of our laboratory, and Ibi Jack, who's a thoracic oncologist at our cancer center, have put in a lot of time and effort in developing this. And it's really amazing protocol and workflow and pathway that we have at our institution that I'm happy to share some of the successes that we've had with it with you. So this is something that we did as a pilot study, started off with advanced lung cancer patients. And the initial pilot was just looking at EGFR mutation, just kind of a proof of concept and feasibility of. And the main goal was we want to get patients that have lung cancer on targeted therapies, if they're eligible for it, as fast as possible, right? So all the way from patient coming in, patient getting a biopsy, patient getting a molecular genotyping result, to patient getting the actual target therapy. Really minimize that time. I think, the goal and the idea of this is maybe we can get somebody on the drug the same day they come in, right? Or even the next day. So I think especially as laboratorians and pathologists like myself, after we issue our final reports, we think, oh, the patient, now they get their EGFR therapy. But in the real world, there's actually quite a bit more time before the patients actually get on drugs. So the goal of this was to form a multidisciplinary team to try to minimize that time. And a key component of this is rapid molecular testing. But as you'll see, there's a lot of other players and partners in this as well. So this protocol starts off with a patient that comes in and is identified as a good candidate for this pathway by their oncologist. So we are notified this patient should be eligible for the ultra-rapid protocol. So then we send an email to our partners and friends over in the specialty pharmacy. So these are the folks that will submit test claims to the payers, do payer medical policy review, so that all the prior authorizations are already taken care of, not just for the molecular testing, but actually for the drug, for the targeted therapy. So that way, even before the patient has a diagnosis and a biopsy result, this whole engine, so to speak, is already started and ready to go. So this also involves coordination with interventional radiology, who's going to be doing the scheduling and the biopsies, our cytopathology team, who will be reading the biopsies, and then our surgical pathology lung group, who will be doing frozen section diagnoses and giving us frozen sections for our ultra-rapid molecular testing. So this is an example. The patient comes in. They might have an EVIS, so an endobronchial ultrasound, and an FNA that's done. The cytopathologist reads it as positive for non-small cell lung cancer. A biopsy is taken, and frozen sections are done off of that biopsy. And we usually get around 10 or so frozen sections from this team. And they send us a page. So we have a specific pager that the folks in our laboratory carry just for this ultra-rapid protocol. They get a page. We go pick up the frozen section slides from the lab, and we come back to our laboratory, and we immediately start testing on our ultra-rapid protocol. And in the meantime, specialty pharmacy is still working along. The dispensing pharmacy is getting ready, so that way, by the time we get our result back, the drug's already been approved and is ready to be dispensed. So here's kind of the full picture of this ultra-rapid protocol, and I won't go to all the details of it, but you can see there's quite a bit of complexity, numerous, 4 different teams within specialty pharmacy are involved in this, many different subdivisions within pathology and our oncology group, all of which with the goal of getting the patient on the right drug as quickly as possible. So it's really quite a bit of work. Many, many different teams and many different people put a lot of effort into creating this pathway. All right, so now I want to talk a little bit about the performance of the assay that we've had in our hands, and then I'll end with some of the really impressive improvements in turnaround time that we've seen with our ultra-rapid protocol. So the whole end-to-end protocol, which, as you can see, has rapid molecular testing is critical, but there's a lot of other key components as well. So the technical performance of the assay in our hands has been quite good, with specificities, 99% to 100%, clinical sensitivity around 95%, and limit of detection around 5% allele frequency. So very robust performance in our hands. And this is kind of our initial clinical experience. We try to run, our laboratory is actually only a Monday through Friday operation, so we try to run this assay every single day. Of course, if you do too much batching and you aren't running the test every day, that reduces your turnaround times. So up to 4 or 5 runs per week, depending on the week and the samples that we get. And so our clinical utilization of the test initially has been these cases in the ultra-rapid lung program that I just told you about, as well as replacing several previous single gene assays. So you can see half of our volume here in this pie chart on the right is lung cancer. And the rest of our volume, many of which, such as melanoma and thyroid is good examples, are because of things like BRAF testing, where we kind of are getting rid of our legacy single gene assays and really trying to streamline testing in our laboratory. And we've had a very low technical failure rate, less than 1%. I think the coolest thing that we've seen in our initial experience with this platform is that if we look at our non-small cell lung cancer patients, which again is about half of what we've been testing thus far, and many of these are in our ultra-rapid program, we're able to identify driver alteration in about 75% of cases, which is pretty good for a pretty focused, small, targeted panel. And the other thing that's been very exciting is that some of these are actually rare variants that were not covered by our legacy single gene rapid assays. So our ultra-rapid and rapid testing program at MGH has been around for quite a few years now, but previously was taken up mostly by single gene-based assays, some of which just don't have coverage for the more rare variants. So for example, EGFR exon 20 insertions, we've identified a more rare EGFR exon 19 deletion that we wouldn't have identified by our legacy assay. And the other thing that's really neat is that the RNA component has picked up, 14% of what you see here on the of the 75% that's making this up are actually coming from things that we identified on the RNA component of the assay. So 9%, as you can see on this purple slice of pie on the chart here on the right were fusions, so Alcaret and ROS1 fusions. And then another 5% where it met exon 14 skipping. So this assay is really useful because it identifies the actual skipping event on the RNA level instead of just looking for splice site mutations by the DNA. So moving on to what I think is really exciting about our ultra-rapid protocol that we have at MGH is the impact on turnaround time. So again, this is the whole protocol, right? So this is not just our test in the laboratory. This is that whole pathway that involves many different teams and many different multidisciplinary groups. Having a fast molecular test is an important component of this, but I just really want to emphasize that this is kind of the whole pathway. So this program started in 2020. You can see this huge dip in our laboratory volume here. This is, of course, the famous COVID dip that you see in any sort of volume-based testing figure. But the bottom panel, panel B, this is the time from the test order to the molecular report. And if you look at the line in red, that is quite a bit lower than the rest of the lines, that is the rapid pharmacy. So this is this ultra-rapid protocol. So this resulted in a very much improved turnaround time, which is great. But again, if we think about what matters to the patient and the clinician is when they get on therapy, right? And so if you look at panel C, this is the time from when the test was ordered to when the actual patient gets to start on TKI therapy. And so these figures were done just looking at EGFR mutated patients. Again, this is part of the pilot study to show feasibility of this entire protocol. And really amazing, if you look at the table at the bottom, this is the time from test order to starting of a TKI in EGFR mutated non-small cell lung cancer. So the patients on this ultra-rapid protocol, on average, got on drug in 8 days. This is amazingly fast. Compared to patients that were not on any sort of rapid testing program at all, they didn't get on drug until 53 days. We're approaching on 2 months, 1 week to 2 months. So that's really a huge difference. And I think this is just really a golden case example, kind of showing what the promise of one of these really integrated protocols is. And this is a patient who came on day 1, got a lung biopsy, got their diagnosis, molecular testing was able to reveal an EGFR mutation, and osimertinib was able to be prescribed, and the patient actually got on the appropriate drug the next day. And you can see by day 48 here at the right, they actually have a radiographic response to therapy by day 48. Now, if you remember from the previous slide, highlighted down here in the table on the bottom right, patients that weren't in the rapid testing protocol pathway, on average, hadn't even started therapy by day 48, much less already had a radiographic proven response to drug. So this entire integrated pathway can really, really improve turnaround times. And I think we've demonstrated that pretty well at our institution. So again, thank you for the invitation. I'm really happy to share this exciting pathway and program and testing platform that we've been very happy with in our laboratory. And again, I want to acknowledge the 2 architects of the ultra-rapid protocol testing in lung cancer, which is Joe Leonards and Ibi Degogojak, and the many, many people in our laboratory here at the CID at Mass General that participate in our rapid testing platform that really contributed to this amazing work. So thanks again.
Hi, good afternoon, everybody. My name is Eric Vail. I'm the Director of Molecular Pathology at Sinai Medical Center, and this is my talk today, Clinical Utility of Amplicon-Based CGP, or Comprehensive Genomic Profile Testing. So here are my disclosures, just briefly, that this is I'm receiving an honorarium from Thermo Fisher Scientific, and this is not for CME. So, diving into precision medicine, you can see here, this timeline goes from the late 90s to about a year or 2 ago. So it's already outdated, of course, because everything's moving so quickly. And you see that there's been this real acceleration from, back in the late 90s with HER2 overexpression and breast cancer, then it was till 2004, solid tumors for EGFR positive non-small cell lung cancer. And then starting in like 2010, we see ALK positive, BRAF positive melanoma, ROS positive non-small cell lung cancer. And we start getting more and more of these approvals that are all basically powered by discovery by NGS of these biomarkers. But I think that even this chart really understates it. This is a great paper. There's a review that showed that from April 2019 to April 2021, there were 20 different genomic targeted therapies. So they need a genomic test to find the target for them to be approved across 12 different tumor types. When we talk about utilization later on in the talk, you're going to realize, how is anyone supposed to be able to keep up with this? This is very high amounts of change that are going through the system. And what ends up happening is that you need testing to be able to cover all of these different things. And not only that, you need testing to be almost forward-looking to be able to cover all these different things, to make sure that you include all of these as these approvals just keep going on and on. So just as a background, let's talk about different genomic testing strategies and how we can test for different genomic alterations in cancer. You really kind of put it into two buckets. So you have your targeted assays. These are like when you think of the single gene assays and stuff like that, and then your broad assays. In your targeted assays, you have FISH. So this is great for translocations and CNVs. I'm sure most people here have experience with an ALK FISH or a HER2 FISH. Work very, very well. Very sensitive, very specific, and allow single cell resolution. But again, they're only really looking at that one thing. PCR looks at small variants, SNVs, indels. You can have RT-PCR to allow for fusion detection. You can have or using for expression of RNA transcripts. And then there's the old workhorses, Sanger, and what I like to call baby NGS, because it sort of works the same way as NGS, but just in one target, pyrosequencing. And these also allow for small variant and indel detection, but they're doing it in a sequencing way, so you're actually getting a sequence instead of just detecting an allele. And then they can also be used for fusions as well. But again, these are targeted to a single region of the genome, or if they're multiplexed, up to 5, 10, 20 regions of the genome. On the broad category on the right, you can see going really from low resolution to high resolution, right? And so karyotypes, what you get, this is the first whole genome assay, right? This allows you to look at the entire genome of a cell, but the resolution is 5, 10 million base pairs, 10 million megabases. But really, it's great to look at aneuploidies, translocations, and everyone's been saying that karyotype is going to die. Maybe these new technologies like optical genome mapping and stuff like that will finally usher in the end of the conventional karyotype, but it has been the standard workhorse for this type of testing for a very, very long time. Then there's microarrays, which offer a lot of the benefits of karyotype, but obviously can't detect balanced translocations, but with some significantly increased resolution. And so you can see microdeletions, you can see things down to about 25, 50,000 base pairs. So CNVs, methylation expression, there are some microarrays that do have individual SNV detection wells in them as well, so that they can be used as sort of a cancer type assay. But really that's almost like cheating. It's kind of like having like a sidecar single gene assays. And then there's NGS, and this is next generation sequencing, massively parallel sequencing. And this has the ability to detect all of these different variant classes, along with some pangenome markers as well, while being all really in one assay, right? So one assay to rule them all, sort of thing. Obviously, you need to have specialized preparation or sequencing protocols if you're going to do something like methylation bisulfite sequencing. But in general, you can fit most of these things into one assay. So, NGS testing has kind of bifurcated into two styles of testing. You have these small hotspot-based panels, and you have CGP, or comprehensive genomic profiling, or what's being called that. So with the small panels, these are generally 5 to 50 genes. Why 50 genes? Because that's what the billing code is, and so that's how these things sort of end up getting made. They're almost always amplicon based, and I'll talk about amplicon or hybrid capture on the next slide. But because they're amplicon based, they are very low input. They're rapid, and previously they were usually DNA only, but actually now, because they've been updated so frequently, most commercial kits are DNA and RNA, and so they allow for this better detection of fusions with RNA. Because they're small, so they don't have a lot of baseline to generate, and because amplicon in general has more challenges with copy number variations than hybrid capture, they struggle with CNVs, especially deletions. And so generally what you'll see is that they'll be able to detect like high amplifications of like HER2 and MET and stuff like that. But they're very clinically targeted, right? And so like if you're doing screening of lung cancer samples, these are perfect single gene replacement assays. Then there's CGP. And CGP, the definition of it is in flux still. I think that it's not perfectly standardized, but really what it means is that it's something that detects all of the different variant classes with a large number of genes and can detect some of these pangenomic biomarkers. So it's hundreds to 1,000+ genes. I remember the exome is 20,000. And so this is capturing, if you're in the thousands, you're capturing a large percentage of that. Usually, these are hybrid capture assays. There are some on the market that are amplicon based, but that really pushed the limit of that technology. Because hybrid capture requires higher input material, they generally require anywhere from 5 to 10 times the amount of nucleic acid that some of these smaller panels require, and they're slower. Most of the CGP type assays are moving to DNA RNA, but because some of the older ones that first came out got FDA approved and can't change anything when you get FDA approved, they're kind of stuck in this DNA only paradigm, which obviously has issues for fusion detection. Because hybrid capture doesn't need to know the partner of the fusion, they are able to detect novel fusions a little bit better than amplicon-based panels. One of the things that obviously they have all of the stuff that these small panels have. They have all these clinically targeted areas and things like that, but they also have large swaths of the genome that there aren't any current clinical indications. And what that helps for is things like clinical trial recruitment, discovery, and all these things that lead to the progression of our knowledge in cancer. And so these are great for big academic institutions, big reference laboratories, things like that. And so just to go a little deeper into amplicon versus hybrid capture, basically the difference here is how you are selecting the material that you're going to sequence, right? So how do you isolate and how do you make it so that you only sequence the areas of interest from the genomic DNA that's given to you after extraction, right? With the amplicon-based NGS, what you do is, or an amplicon library preparation, what you end up doing is that you massively amplify with targeted primers the areas that are of interest, right? So the targeted areas of interest. This means you only need to start off with relatively little nucleic acid. And so the assay that we use a a large amplicon panel. It says it uses 20 nanograms of input. We've gotten results down in the 1, 2, 3 nanogram range, and regularly have success with 10 nanograms. And so both on the DNA and the RNA side. That amplifies it up. Then you get your barcoding, your adapter ligation, and all that stuff. And then you have your library, which then can be templated and sequenced, or just loaded onto a flow cell and sequenced. With hybrid capture-based library preparation, what you're doing is you end up with the DNA, and the next thing you have to do, you have to fragment it. You have to adapt your ligate your adapters, and then what you do is you hybridize the areas to these beads that have specific the specific panel locations of the genome on them in the antisense, and then that's pulled down, right? And so you basically, instead of amplifying up the areas of interest, you pull out the areas of interest. There's some benefits to that, right? You don't need to do huge amounts of PCR, so you don't end up with amplification bias. You are able to get a cleaner kind of backgrounds for, especially for copy number calling, because of this, and baselines. What you don't always perfectly hybridize everything, and so some non-targeted sequence will come out, and this can allow for like virus discovery and stuff like that in these non-targeted regions, so you can get some benefits from that. But because of that, it requires more input nucleic acid to begin with, right? Because you're not really boosting the amount, you're actually decreasing the amount of input into the system. It also requires longer time. So PCR takes significantly shorter than hybrid capture. And so depending on the sample you have, if you have a perfect sample, the best sample in the world, 100% tumor cellularity, a pound of it, and you can throw that in, get extraction, get micrograms upon micrograms of nucleic acid. Hybrid capture based NGS really it performs fantastically. But when you end up with degraded FFPE, real world samples, itsy bitsy little biopsies, things that are challenging, amplicon based NGS really provides that cover to allow for sample rescue. And so, our QNS rate is in like the 2% range. And that's all because we're able to basically get all this tissue in. So what are some of the clinical benefits of tumor profiling? Really think of it in diagnostic, prognostic, predictive. Diagnostic to help find what the diagnosis is, prognosis to see how the patient will perform, and then predictive if there are any targeted therapeutics for them. I've provided 2 examples of commercially available hotspot panels on the right, and really what these do is target these targeted therapeutics. So a lot of what they do is finding drugs for the patient, which is a huge clinical benefit and one of the main clinical benefits of sequencing. But what they don't do is help out as much with these other 3 things, with the diagnostic, prognostic, or for enrollment in clinical trials. Because of that, CDERS has, slowly over time increased the size of our NGS panel offerings. And we've gone from a 50 gene panel that was hotspot DNA only to a 161 gene panel, DNA RNA, down to a 500 gene panel that we're running right now that also is DNA RNA, but also can detect, tumor mutation burden, microsatellite instability, and has some functionality around genomic instability. So entering this kind of second part of the talk, looking at some of the different utilizations and case-based structure of comprehensive genomic profiling in cancer. I'm going to go over tumors of unknown origin. So this is a case that we had. It was a 70-year-old man with an enlarging 6 centimeter submental mass, so right under the chin. And pathology shows this, what we see here on the right. So pleomorphic, spindle cell, focal myxoid areas, everything was negative. Like all the IHC, everything was negative. And based on some radiology, based on sort of minimal and equivocal involvement of the overlying skin, the suspicion was around primary head and neck sarcoma. So we did sequencing on it, and what did we find? We found hundreds of mutations. So we found TER promoter, RAC1, PTPN11, Sybil, a TMB of 63 mutations per megabase. And if you look at what they were, is that almost all these mutations were these C to T transversions, or actually even better, these double Cs to double Ts. And I will tell you, if you see lots of double Cs to double Ts, you are dealing with a tumor that has been exposed to UV light. This only happens in those tumors. Here's the cosmic singles base substitution patterns. So this is SSB7A and B. This is associated with UV light. And if you take these up, you put them up next to the patient's pattern, you can see that it has a distinct and pronounced UV mutational pattern. What we found was that this RAC1 mutations in melanomas are associated with this mesenchymal phenotype switch, and so they end up looking much more mesenchymal. They express mesenchymal markers. They lose a lot of melanoma markers, but they end up being melanoma. So this is actually found out to be a melanoma, and this is the age-old adage in pathology is that it can always be melanoma. For just some more information on this, these are a couple studies. One's from University of Michigan on the left, one's from Foundation Medicine on the right. The University of Michigan study looked at a subset of, I think it was 55 cancer of unknown primary, and they were able to basically help classify them in half of the cases. And then in those unknown primary cases, 14 of them ended up getting a therapy, with over half of the patients that got a therapy deriving clinical benefit from the therapy. So cancers of unknown primary are a great place for genomic medicine to help basically in all three of those categories: diagnosis, prognosis, and predictive value. On the right, this was a trial that was run looking at the ability to enroll patients on this multi-arm trial for tumors of unknown primary, and they were able to basically get a third of their patients on trial. The next kind of case set that I'm going to talk about is this dilemma that we have in lung cancer of synchronous primaries versus metastasis. And so I'm going to give you a 64-year-old female. She had a 40-pack-year smoking history, and then underwent a screening CT. So this was caught by screening, and she had two masses. One in the right upper lobe, 2.6 centimeters. One in the left upper lobe, 1.8 centimeters. And you look at the histology here. Are they similar? Yeah, they look like adenocarcinoma, right? Like maybe the one on the right is a little more eosinophilic. The one on the left, it's tough, and so it's tough to say just based on morphology alone what these are. And if you look at their immunostaining patterns, they're both TTF1 positive. The one on the right was there was a thought maybe some adenosquamous components, so they ran a P40. Napsin was plus minus, some patchy positivity. So they are a little different in their staining patterns, but not enough to really say, oh, this has to be two separate primaries. And on imaging, there was some hilar mediastinal lymphadenopathy, and as every radiology report says, reactive versus metastasis, right? So not a lot of evidence there. And so for this patient, these are hugely different scenarios, right? If she has synchronous primaries or if this is metastasis or if this is intrapulmonary metastasis, because this literally goes from two stage 1 tumors depending on the lymph nodes, or stage 1 tumors depending on the lymph nodes, to stage 4 disease. So what do we find in NGS? Both had a KRAS G12C mutation. Now you go, oh, it has to be the same tumors, right? And if this was a hotspot panel, this would have stopped there. And I think that we would have said to them, KRAS G12C is in 25% of smokers. So that means the odds of this happening are 1 in 4 times 1 in 4, right? That they could be synchronous primaries. That's 1 in 16. And I don't know about you, but I don't especially want to bet on a 1 in 16 thing. That seems really still within that realm of that could be challenging. And because we ran a large panel, what you end up seeing is that all of the rest of the mutations are completely different. And so this is pretty conclusively shown to be 2 synchronous primaries versus intrapulmonary metastasis. This was a great study that was done out of MSK, and it looked at 76 tumor pairs on the 2 different versions of their impact panel. And what they, and this is all in the same sort of scenario, intrapulmonary metastasis versus synchronous primaries in lung cancer. They were all able to be molecularly characterized, and they had really good statistics on this. I think the one with the lowest level of confidence was like 1 times 10 to the negative 55th. So it was like super crazy levels of confidence. And interestingly enough, within that 76 tumor pairs, there were 4 pairs of synchronous primaries that had the same coincidental hotspot mutations, 3 of them with KRAS G12C, and 1 was, I think, KRAS G12D. And so this is not something that is so out of bounds as being not going to happen. This is something that could definitely happen in real clinical practice. And what they did was, and this is really interesting, they looked at both. They had histological prediction. So they took the pathologists and they said, how good, you choose, do you think this is going to be intrapulmonary metastasis or synchronous primaries? And, pathologists were right about 77% of the time, which, to be honest, is pretty good when you're just looking at the slides, right? But obviously molecular is significantly better. And then what they did is they subsampled down to these 50 gene panel, and they subsampled down to basically single gene testing of KRAS, EGFR, ALK, and ROS only. And by doing that, the hotspot panel was actually only able to conclusively determine about 3/4 of the cases. So right around where histologic prediction is. And so this benefit here is really derived from the comprehensive genomic profiling. The last area here is this co-mutation detection. Just very briefly, the way that we look at genomic profiles is genomic pathways is incredibly simplified. You like to think of your tyrosine kinase down to either the MAP kinase or the PI3K pathway, and you have a mutation in one area and you just block it. That obviously isn't reality. And what we know is that these are not just pathways, they are webs. So here's the real MAP kinase pathway on the left. Here's the real, up to our knowledge, PI3K ACT pathway on the right. And you can see that this is incredibly complicated. And one of the reasons why just targeting things doesn't cure the cancer is this level of complexity. And so looking at co-mutations is really important, because what we found is that they impact how patients respond to disease. Here is from the trial for the first KRAS G12C inhibitor in non-small cell lung cancer. KRAS obviously is the second most commonly mutated gene in cancer after P53, and it really was the holy grail of pharmacotherapy development. G12C, because of the smoking-associated damage, is the most common mutation in non-small cell lung cancer, but it's also seen in colorectal cancer. And And what the exploratory analysis on the CodeBreak 100 trials showed was that they were looking at these genes STK11, KEAP1, and P53. And the reason was that there had been previous evidence with STK11 and KEAP1 specifically about responses to different therapeutics. And what they saw was that in KEAP1 co-mutated tumors, there was a trend towards significantly worse responses than KEAP1 wild type. And actually, when you combine them all together, the statistics actually become significant. In BRAF positive colorectal cancer, remember BRAF V600E is now a pan-tumor indication, but in colorectal cancer, it's a little different. You can't just give the BRAF MEK inhibitors. You have to actually give EGFR and monoclonal antibodies as well. And what they found was that in the Beacon trial that ended up doing this is that they were able to go back and look at this and see who was responding and do additional analysis on this subgroup. And they found that this RNF43 positive subgroup, especially in the microsatellite stable, had basically all of the response was associated with them versus the RNF43 negative subgroup. The final area I'm going to talk about is utilization, and really that final benefit for CGP, which is the education of you, the laboratorian. So testing is horribly underutilized. This is just data across non-small cell lung cancer, colorectal, and ovarian, and it just shows that basically large swaths of patients are not getting tested for the biomarkers that are approved for them. Therapies are underutilized too. This is the Foundation Medicine, the famous Foundation Medicine Flatiron study, which showed significant benefit to receiving NCCN targeted therapies, but also showed that half of the patients in their study cohort did not, these are all patients that got tested, did not receive the therapy that was approved for their biomarker. And then this is a recent study that was just looking at Medicaid data that was in JAMA Oncology, and showing that basically there are only 3 states that have the expected utilization of EGFR and ALK inhibitors for patients with non-small cell lung cancer. And so there is massive underutilization of these therapies. Why is this? As I've kind of alluded to, this is a massively, rapidly changing field. The testing is getting more and more complex. There's confusing reports, bigger and bigger, and payers are more and more stubborn to cover this type of testing. So how can local CGP testing help with all of this? You know, when you run these tests, you have to know them, and being able to know them makes you an expert in them. And being an expert allows your oncologist to come to you, to talk to you, it allows you to keep up with the pace of change. You become much easier to access, much easier to consult with than the large reference labs. Because you have the tissue locally, because you know what you're working with to begin with, the failure rates are lower at local institutions. And you can give this sort of boutique model. You can do things like reflexing lung cancer testing. You can do things like reflexing metastatic colorectal. And having all of these things in place allows for you to conserve tissue. And finally, you have clinical trial recruitment. So this, the more and more testing that you have in-house, the more and more ability that you'll have the ability to have clinical trials come into your institution. And this also provides values not just for the patients and the oncologists, but for the payers as well, because the clinical trial pays for their care while they're on trial. So just as a summary here, CGP has clinical benefit above and beyond hotspot biomarker testing in cancer. Amplicon-based testing, as I've kind of talked about, can have significant workflow benefits when dealing with real-world clinical samples, so your itsy-bitsy distal FFPE destroyed samples. And then local laboratory involvement in molecular medicine is something I'm on a crusade for, and is absolutely critical to improve these obvious current defects that we have in test utilization and patient outcomes because of that. So with that, I just want to say thank you, and if there's any questions.
Well, welcome back live. Thank you both speakers the really outstanding presentation. Quite frankly, I would have myself really a number of questions, but of course, let me take the chance to go and start picking up questions from the audience. So the very first one, it's one of a tricky question, if you want. And it's for Dr. Ritterhouse, which once again, I have to say, what you have been able to set there, it's nothing short but astonishing. It's really outstanding what you have achieved there in terms of a rapid lung program. But now the question is about, it seems like you still have a 1% failure rate, which to me seems to be close to nothing, but the audience still is asking what kind of samples are actually not going through. I would have a different kind of question, but still, for the sake of transparency, I'm asking you anyway.
Yeah, I mean, there's a just, you know, as Eric can attest to, there's an enormous amount of pre-analytical variables that happens to tissue that comes before it even comes to our laboratory, right? Sometimes there's no tumor left at all. When we get sections, you know, maybe they send us an H&E and there's some tumor, and then we cut some more sections and then there's no tumor left. Sometimes people try to test bone specimens that have been decalcified with acidic, you know, things that destroy nucleic acid. So, you know, there's only so much that a certain testing platform or laboratory can do. You know, it's you know, kind of, we're limited by what we get. So there are some limitations. We can't create tumor, you know, out of thin air. But you know, I think that kind of failure rate is pretty impressive and a lot better than many laboratories, especially commercial laboratories.
Absolutely. Maybe if I can just ask Erin, any comments from Eric? Any comments from your side? Would you say 99?
If we're being asked to get better than 1% failure rate, I give up. That is astounding. That I don't think you know. Once you start getting it below 5, and you know, Dr. Ritterhouse and myself, we work at really great institutions that have fantastic histopathology laboratories that cut down on a lot of the I think pre-analytical problems that can happen in other places. And so it's a credit to us that those exist, and that's one of the reasons why we can get such low numbers. But you know, even in the community, these types of platforms are able to do very, very well and get under the 15-20% that QNS rates that some of the big reference laboratories have.
All right. Well, appreciate the answer from both of you. I think we could be all very satisfied with the 99% success rate. So moving on now to the second question, which is about RNA fusion testing. That it's actually for both of you. The question is, once you picked up an RNA fusion, for instance, a rat, an ALK, or even a more rare fusion like an NTRK fusion with one of your NGS approach, either being a large or a small panel, do you still cross-validate that fusion with an orthogonal method such as FISH, or you actually no longer need to do that? What is your experience in that?
Yeah, I can speak first. It depends a little bit on the assay and the way it was detected. The only fusions that we would ever orthogonally confirm is if we're running a particular test that only flagged it as an expression imbalance, right? So one of our assays we'll call an expression imbalance, but it doesn't detect an isoform, then we might try an orthogonal test. But if it, if we see, a classic fusion isoform, that's not going to get confirmed by another test.
So with these amplicon based panels, there's sort of 3 ways to detect fusions. There's the targeted, so like it was designed around seeing that. There's the 5' 3' imbalance, which we also, if we see and there's no other drivers and there's clinical suspicion, we will attempt to confirm that with another assay. And then there's the non-targeted fusions, which is basically you have primers in the pool. They were designed to work with other another partner, but
they were able to catch a fusion between a non-targeted driver and partner gene. We were in the very, very beginning of running these types of assays, double checking those, but they were so solid that we never found a single false positive that we stopped doing that too. And so in general, they have amplicon-based fusion detection on the RNA has incredible sensitivity and specificity, just like 99.9 sort of style amounts. And so no, there's no reason to double check those.
Thank you very much, both of you. Now, this is a question about the incredible turnaround time that you have been able to achieve, Dr. Ritterhouse. And actually, the very same question was asked in the EMEA session a couple of hours before to Professor Paul Hoffman, who is a very well-known and internationally recognized pathologist from the University of Nice in France. So he has a very similar turnaround time to the one that you have shown by using this ultra-rapid NGS approach. They've also established a rapid lung program in Nice. And the question that came from the audience, which is exactly the same from here, I'm not sure if it's from the same person, but the question is about liquid biopsy. Now, with such a super ultra-fast turnaround time for tissue, what's the real advantage of using liquid biopsy now? Because basically, again, you can do it in 3 days, which for many years has been the argument of the people supporting the adoption of liquid biopsy because it was faster than tissue testing. Could you share anything around that?
Sure. I mean, some of it is logistics, right? At our institution, our oncologists take liquid biopsies on everyone at certain clinic visits and appointments and that kind of thing. There's quite a few arguments on proponents of liquid biopsy that it might be a better measure of heterogeneity than just a 5-micron section of tissue. So you could come up with some things. But if it's a new diagnosis and you're looking for a driver alteration, and you find it on your rapid test, was there a real sense of clinical utility? I think particularly maybe at academic institutions, there's a lot of maybe duplicative and parallel testing that's not completely optimized, and maybe some waste of resources, one could argue. But yeah, we talk about this a lot. Right now, when we do an ultra rapid testing, we don't stop all the other testing. We have because right now our ultra rapid lung program is a very hotspot focused. We still do a parallel, more comprehensive, larger panel. So we've discussed, once we get a driver result, then when we cancel, whatever workflow has started for the other tests. And that's something that we haven't implemented yet. But I think some of these things are kind of more workflow logistical questions and haven't been totally resolved.
All right. Well, appreciate you sharing that. And that's now a question for both of you. Are you planning to do an ultra-rapid liquid biopsy program for lung, not just for tissue?
No. I think at diagnosis, tissue is the gold standard, and I'll fight that over and over and over again. I just think that you're going to have to get tissue anyway. The biggest advantage to liquid biopsy is you don't have to get tissue, right? Like that's the biggest advantage. And so if you're in a situation where you have a diagnosis, but there's like it's like a smear that has five malignant cells on it or something like that, then it's a little old lady. You don't want to go back, rebiopsy them, and this is where liquid biopsy works beautifully, right? But in that for at diagnosis, it's the gold standard is tissue-based testing.
Yeah, we don't have any plans in the immediate future
to do that. Okay, thanks. Apologize for interrupting. I think we have so many questions. We won't be able to address all of them. So if you don't mind, I'm just going to pick 2 more, one each, or again, feel free to comment, both of you, and then we'll be moving forward. So this one is actually for Eric. Eric, what other additional advantages you see in the large panel testing when it comes to complex biomarker, and have you experienced in your routine testing utilization of things like TMB or HRD. Do you see them as the only added value of large panel, or anything else you can add on that?
So TMB is pretty much, you have to have a large panel, right? So like the minimum to get statistically valid results really starts around a megabase of coverage of genomic area, and so if you can't, these small panels are like 50, 60 kilobases or something like that. You just can't do it. It's not possible. Whether or not tumor mutation burden is a good biomarker is a debate for another point. But just for the analytical detection of it, you have to have a big panel to do it. So that's the first thing. HRD is a really complex, genomic instability is a really complex sort of thing there. It's even less mature, I think, as a biomarker than tumor mutation burden. The definition of tumor mutation burden, at least, is mutations per megabase. What is the definition of HRD? Well, we're working on it. But just having that there and having the ability to do that sort of detection in the assay, of course, it's a plus, right? Because that's the beauty of NGS. You're doing all of the things that you are clinically relevant, and then you can add on other stuff for minimal increase in cost to be able to future-proof the assay, so that when this stuff gets more integrated into standard of care, when this stuff gets more standardized and harmonized across assays, you have the ability to do that and validate it.
Well, thank you. Just a flash one. Both of you, do you think HRD story gonna end up as the TMB story, which quite frankly was a little bit messy in the end, or there's hope that this time we manage as a community to make it a little bit better?
It could be worse.
Yeah.
If you want a real answer.
It's levels of complexity more difficult than TMB. So yeah, I don't imagine it going the other direction. Okay.
All right. Well, a lot of work ahead of us. The very, very last question. This is actually a very good one. Dr. Ritterhouse, for you, you show this amazing turnaround time. But the people are asking, are you planning also to, now that you have enough cases, are you also planning to measure the impact on clinical outcomes? So in other words, are you adding survival to this patient?
Yeah, that's what all the reviewers at the journals like to ask us about when we submit our data as well. Yeah, I mean that's the goal, right? And this is an argument that we have a lot when we talk to various groups about rapid testing. Like, does it matter, right? Does it matter if you start the patient on drug a week early, 3 weeks early, a month early? Is there any impact on patient outcomes? So yeah, that's something that we definitely want to collect. It's really hard to do outside of a prospectively controlled trial, but it is a goal of the program to actually get outcome data. But yeah, it's a great question.
I think that is in fact the real question, and we're very much looking forward to see that data. Meanwhile, I would like to say once again to both of you, outstanding presentation. Thanks for sharing your experiences and your great knowledge. It was really a pleasure to have you with us. It was a little bit a longer Q&A, but I think we had a very good discussion. So once again, thanks for participating in this event, and I wish you a fantastic rest of the day. We're now going to have a break. We will reconvene here in about, it's going to be a little bit shorter of a break. So we will get back here in about 8 minutes, if I'm not wrong. So please take the chance to go and visit the Oncomine environment and be back here at 15. So see you soon. Thank you very much for being with us.